Hi everyone, good evening. My name is Sebastian Roy. I'm a treasurer here at the New York HIMSS Chapter. Welcome to a free webinar for our membership on COVID-19 vaccine logistics. We have a great event for you all today and we're very excited to have you here. Before we get started, we have a few logistical items to get through and then I'll pass it over to your presenters for the evening. First up, we'd like to let you know that there is some closed captioning for the event this evening. If you'd like to turn that on, it's automated closed captioning available in multiple languages. You'll be able to see the words that are spoken, generated by AI on your screen. There's also a Q&A function, so you all as the attendees are able to ask us questions throughout the webinar. We'll be moderating those questions and feeding them to our panelists for them to answer your questions live. So feel free to ask any question you have at any point during the event using that Q&A button that looks like a question mark as illustrated on the slide that I have right here. If you run into any technical difficulties and you are using a web browser right now to view this live stream, please just refresh it. And please note that our event will be recorded and we'll be uploading the recording to our YouTube channel and posting it on our website within about 2 to 3 days from this event. Next up, we'd like to encourage all of you who aren't already to become members of HIMSS and members of the New York chapter. So to sign up for HIMSS as a member, you simply need to visit marketplace.himss.org. And if you'd like to see all our free events that the chapter puts together, please visit our website. You can type in that email address, NYS HIMSS Chapter.org, or use the QR code from your phone to visit it right now. So that's it for the preamble. Now I'll pass it over to Margaret, who will be introducing your moderator for today.
Good evening and welcome to our virtual conference. COVID-19 vaccine logistics. This virtual conference is presented by New York State HIMSS Events and Communications Committee. My name is Dr. Margaret Bania. I would like to thank the members of this committee who work together to provide this conference for you. Anthony Ferrante, Nicholas Cristiano, Sebastian Roy, and Amin Hakim. Now I would like to introduce our moderator. Dr. Amin Hakim is a physician consultant with EMZ Solutions and an infectious disease specialist. Dr. Hakim has been a proposal reviewer for the HIMSS annual conference. Dr. Hakim has held C-suite positions at several organizations and is a member of the editorial board of the Physician Leadership Journal and the American Association for Physician Leadership. Please welcome our moderator, Dr. Amin Hakim.
Can you hear me or?
Yes, we can.
Yes.
Okay, great. Just making sure. So thank you, Dr. Bania, again, and welcome everyone. This webinar is focused on logistics for the coronavirus vaccine. We'll start first with introductions of our presenters. So first, may I ask Patti, would you please introduce yourself?
Finding the unmute button first. Hi, good evening, everybody. My name is Patti Cuartas. I am an executive director and associate CMIO at the Mount Sinai Health System.
Okay. Dr. Raul, or Raul?
Yep. This is Dr. Raul Vasquez. I'm sorry that I'm wearing a mask. Hopefully you guys can all hear me. Yeah, I'm a family physician in urban family, up in Buffalo. I run an accountable care organization. I'm kind of in the midst of all this COVID-19 going on.
Okay. Megan?
Hello, I'm Megan Cardona, and I am the current clinical pharmacy manager at Ellis Hospital in Schenectady, New York, and have been a large part of the vaccinations here in the capital region.
And Marty.
Hi, I'm Marty Pierce. I'm a public health epidemiologist with Jevity Consulting based in Victoria, Canada. And I've worked my career on public health information system development and deployments, have done a lot of immunization and inventory management around public health practice, outbreak management, and communicable disease support. A lot of the time we're spending actually working through the business process redesign to help with inventory logistics systems, so have focus there across Canada and in the Middle East. Thank you.
Well, thank you to each and every one of you for being here and talking with us today about COVID-19 vaccine logistics, what we've learned from the rollout so far, and what kind of lessons can we take with us going forward. So I'll start with you, Marty. You, as you just mentioned, you work on the COVID vaccine logistics internationally. So would you share with us what you think of the vaccine rollout? And we'll start with the international scene and then kind of shift to the US and or North America kind of view.
Certainly. Thank you, Dr. Amin. Good evening, everyone. So we just pulled together a few numbers. All the EPIs, of course, like to kind of talk about numbers when we can. And just a couple different perspectives on things. On the left-hand side, we've got a graph basically showing coverage by kind of the top 10 or 12 countries in the world. So essentially proportion of their people that have received doses of vaccine. And certainly the world leaders at this point, and some of the ones that were very early out of the gate, we see some Middle Eastern countries, Israel, United Arab Emirates, to name a few, and the UK, and some interesting dynamics happening in that region of the world. Certainly with Israel, they had a partnership essentially with one of the producers early on, and had agreed to provide probably a bit more information about their population and coverage than we've seen from other countries, in exchange really for early access to vaccine. And of course, they have an interesting set of cultural features in Israel. Compliance has been very high and uptake has been very high. On the right-hand side, more oriented in terms of total doses provided across countries. And of course, United States right now sitting at the top of that list in terms of total doses provided, followed along by China, India, and the UK. The UK is certainly an interesting one in terms of the research and manufacturing capabilities that they had, and the partnership with universities and manufacturers in how quickly they had approvals in place and how quickly they managed their rollouts, and certainly have some very unique and effective information systems to access and communicate with their populations quickly. Thank you, Dr. Amin.
And just Amin. Thank you, Marty.
Okay.
So you have here kind of doses per 100 people, which kind of puts things into perspective. So kind of take us to sort of the North American view, the US view. Obviously we have attendees here that probably more in the New York State area, but I think we have attendees actually from other parts in the United States, and I don't know from Canada too or not, but so yeah, walk us through this.
Certainly, yeah, thank you. I think this perspective is interesting, certainly given border closures between Canada and the US at the moment for all but non-essential travel. It looks like those will be extended Right now they're set to the policies in place through the end of March. That looks like it'll be extended through April, and I wouldn't be surprised if it was extended beyond that at this point. Certainly, from the Canadian and Mexican perspective, we're well behind in terms of coverage. Canada being an interesting situation, we don't have our own manufacturing capability. We have ordered from quite a number of different manufacturers and are starting to ramp up the delivery. So we should see that increasing really quickly. And really, I think from a open borders perspective and getting the economic flow between our North American neighbors going, vaccine coverage is going to be vital. And not only within the U.S. and unfortunately the U.S. is still kind of the world leader in terms of number of cases as well. So that comes into play. So we're all eagerly encouraging you to continue quickly with your immunization protocols. But I think equally in Canada, we're pushing hard to get vaccine out to our vulnerable populations as quickly as possible and to roll out to the remainder of our populations. And the Canadian target right now is probably mid to late summer. And I understand your new president is pushing for the end of May, which would be very encouraging.
If we drill down, well, there you go. The United States kind of drilling down into different regions of the United States. So take us through that, please.
Yeah, and I apologize, the slide has turned out to be a little bit smaller than anticipated, so hopefully folks can see this. Again, on the left-hand side, we have really the top 10 states and affiliated territories, I guess, arranged by coverage, essentially, percent of the population that's been covered. And certainly from the state's point of view, probably the relatively smaller ones are popping out in terms of population. Seb, I think we've lost the slides there. There we go. And we'll see that as we move into the right-hand side of this, in terms of number of doses actually provided, the larger states in some cases are outstripping many of the country numbers that we saw in the earlier slides. So encouraging. It looks like New York State is up towards the top in terms of the number of doses administered. And as you move through that kind of top 10 or 12, we start to see that most are in the 20+% coverage at the moment, with quite an impressive number of doses actually administered. Honestly, the scale of this operation really just comes to light when you see those numbers being put forward, and I think it is very impressive. Amin?
Thank you, Marty. Megan, Marty just took us through some of the data here and variations, and you see on the right-hand side, New York State, it comes in force at 27%. And I'd have to look a little closer at the numbers, but tell us about your neck of the woods. What do you think of the rollout so far, and what changes took place in your region? And remind us all as to what part of New York State you're in.
Yeah, so I am in Schenectady, which is right in the capital region in Albany area. And so the rollout has been a little bit challenging, I guess. It's been bumpy definitely along the way. The way that doses were allocated in the beginning was a little bit bumpy for us, just determining how you're going to prioritize people. Because initially, and even now, there weren't enough doses to hit, in our own hospital system, everybody that needed a dose. And so that was a little bit challenging, even just getting the doses and how quick the Department of Health wanted us to administer them, the logistics of getting enough people to administer, having the consent, getting people registered in the system, making sure it crossed over to NYCIS in our area. All of that was very tricky in the very beginning, and I do think it's better now. We're kind of in a good flow of how many vaccines to request weekly, how we're going to schedule appointments, and the state has provided a scheduling tool now that we're utilizing. And so there's been a lot of changes along the way. And I think as a whole in our region, we do seem to be doing pretty well now that we're, 3 months into it.
Well, thank you. Raul, how did the vaccine rollout work in your region?
Yeah.
And again, remind us which part of the state you're in.
Yeah, we're in Western New York, Buffalo, New York, and I'm sorry it's a little noisy back here. I think for us, the fact that, they allocated the vaccines to hospitals, FQACs, but really left primary care doctors out, became a real issue for us. And in the communities that I serve, the Black and brown population, you still have hesitancy, and they're still not getting enough of the vaccine, even though we've tried. So I think, the people that were affected the most are really not in the front of the line right now. And I think we're just trying to get more access to vaccines. I put orders for my office back in December. We still haven't had one single order filled. I've been able to give about 2,600 vaccines, but it's because I partnered with some of the pop-ups that the state was setting up, and they invited me to come in. So that made it a little bit easier. And, we gave Moderna and Pfizer. We got pretty well educated on what to expect with the vaccines. And at least we were able to touch some of the community. But I still got about 15,000 lives in my practice that we haven't, if I vaccinated 10% of those, that's it. And these state-run vaccination programs, while they're good, there are a lot of times, I think the system, the way it's structured, we tend, when we set these shops up, like doctors, we get vitals on people, and then there's a waiting system. We're used to scheduling people for follow-up, so it's part of what we do in primary care. A lot of those things aren't being following, at least what we're seeing with some of these vaccine deployments. And the education is real important. I don't think we're doing a very good job at that. So while, it's the largest deployment of a vaccine in the history of this country, I think, we could do better. And I think for Buffalo, I'm always crying for more vaccines because we don't have enough. And I think education, we were able to kind of fight and get some Native Americans some vaccines, where we were able to give them 350 vaccines among that area. That's often an area that doesn't get tested or vaccines, and their healthcare models are not as good as most people think they are. So, those are the things that we've experienced in Buffalo. And I think it's important that we start doing a little bit better, because if you look at the number of vaccines that Latinos and African Americans have gotten based on the total population, the vaccine is still not enough to cover the entities that were affected. And we're not, we haven't really connected the actual hotspots where the vaccines, where the conditions occur with COVID. We have 29 million cases of COVID. We haven't really mapped the vaccine component there, because I think it's real important to really target those individuals that may get reinfected if we don't do a good job with it.
Thank you, Raul. Patti, you're in New York City, part of a health system. So how did the vaccine rollout work? We'll get later with each of you in terms of how you started your program and challenges, but what do you think of the vaccine rollout in New York City?
Very smooth. I don't know what these people are talking about. No, I'm kidding. Unfortunately, have the distinction of being a health system both in the city and in the state. We have practices, outside the city. We have a hospital in Long Island. So unfortunately, we have direction that didn't always agree with each other from the city and the state. And that was from the beginning, and it's gotten a little bit better, but it really just made for challenging rollout. Let's just continue using that word because it's pretty neutral, but it could be better. It's getting a little bit better, and obviously the supply itself of the vaccine was also a huge factor. And I share Raul's, comments obviously with, yes, we're a hospital system, and we were given, because of being a hospital system, we had the ability to get these, ultra cold freezers to have the Pfizer vaccine. But we're also sharing and trying to get it out into the community as much as possible, so that it's not just at the hospitals, but in the community that we serve.
Thank you, Patti. Raul, back to you. You mentioned a little bit about how your vaccination program kind of started. So you have your 15,000 patients, and you requested vaccine for them, but then you have your partnering. So tell us about that partnership and how your vaccination program is working in that context, because that's different from Megan and Patti.
Yeah, I think we partnered with a lot of the community-based organizations and the churches. And, initially I wasn't a big fan of it, but what we found were there were a lot of individuals that lacked primary care. So they were able to show up there, and we really had a major impact with the Black and brown population. I mean, so, at least we were targeting the people that these sites were at within the zip codes. And I think that was real important. It was just interesting enough to kind of, these community-based organizations have, centers that are large enough. So, we were able to do 350 to 360 people within 4 hours because of the setup and the scale. And, our teams got pretty comfortable. I think you need a primary care arm or someone that's going to be helpful in the system, and hospitals are not equipped for that kind of volume. I mean, if you look at the community involvement, and while some hospitals did well, if you looked at their total vaccination rates within the hospital structures, they weren't very good. You had people cleaning, cooking that didn't get vaccinations, and you saw hotspots in that area. Outside in the community, it was a little bit different, and I think it was very nice. Especially, we did one with the Native Community Health Center, getting the natives in and doing that, and then the Father Bell. These are all community-based organizations, Mount Olive churches. It brought a different flavor to it, and I think it kind of helped. We created a bunch of ambassadors, and people felt more comfortable with taking the vaccine. But we have about a 45 to 50% hesitancy rate within the Black and brown and Native population, and education is going to be real important in terms of the health literacy within these communities if we want to get to 75% of the urban immunity. So I think trying everything, but really not forgetting what primary care does. I mean, we're the ones trusted by a lot of our patients, and that whole process, they're already integrated within our systems, so it doesn't take a lot of work to process everything. Because outside you got to get all the information, you got to get the forms, and then there's a follow-up that takes place. I mean, we did it in the pop-ups, and about 70% of people didn't have insurance. We're still doing it, but we're a private practice. And we did it because it's important to do, but you don't see the same from other entities around the area. So I think it's really important for us to, this whole thing happens because of not only just the vaccinations, but the lack of primary care and the chronic disease management in some of these communities. So I know we have one particular issue, but we can't forget that these other things are real important right now, because it's not the one-time situation that we're going to run into. It's going to be more times that we're going to. This is the new norm of how we practice medicine.
Right. Thank you, Raul. Back to you, Patti. How about the launch of your program in December? There's probably some work that preceded that, leading up to it, and so let's have about how did you set up the program? Obviously, there things may have changed by now, but let's focus just early on.
Yeah.
How did it go?
I mean, we started obviously towards early fall, anticipating that we were going to get vaccine, and still kind of watching the tea leaves to see which one was going to get through the FDA. But we did try to get ahead of it as much as possible, with our EMR, starting to build the order sets, starting to build the questions, and again, anticipating sometime around November. I think we all remember possibly that infamous weekend of December 12th and 13th when, we got both the EUA for Pfizer on that Saturday evening, and then the executive order from the governor on that Sunday evening, and basically putting the rest of the information that we needed into action, not just on the IT side, on the EMR, but who could vaccinate. We had to start creating BLS courses quickly, because it was one of the needs in the executive order that anyone who would vaccinate needed to have BLS. And we had a lot of physicians who wanted to vaccinate, and nurses and everyone else, and not everyone had it's because of COVID and the pandemic, we're in a lot of BLS classes. So you just as trivial as that, we had to ramp up. And it is a different, I guess, 3 months later, it is slightly different. We've gone into a good cadence. A few weeks after that, Moderna came out. We got ready for that as well. But it literally was from that weekend in December to that Tuesday, December 15th. Early morning, we got a shipment. 1 p.m. we had shots in arms, and it took a village, and it still does.
Right. Thank you. Megan, I know you told me before that your program started one way and then evolved. So let's stick with the beginning of the program.
Yeah, so our program, very similar, I think, to Patti's experience, but we prepped as well as we could when we knew the vaccines were coming. We ordered an extra ultra-low freezer just in case, which were of course already on back order by that point. So it was really a concerted effort between pharmacy, who kind of took the lead because we had an ultra-low freezer, nursing, and our leadership at the hospital, and just trying to, find the best way to get vaccines in arms as fast as possible. And we, that same weekend, like Patti mentioned, we knew it was coming. We got a shipment on Monday, and the Department of Health said, you have to start vaccinating by this evening. And so it was just kind of a rush to get, like she said, everything in the EMR, find arms for it, make sure, we're drying it up, we're storing it correctly. And it was just kind of a, nothing went exactly to plan, but we eventually were able to, get things going, and it is much different now. But in the beginning, it was just kind of a mad dash to get everything in place and really work together, again, to find immunizers, to find the people who qualified for the vaccine very first, and just get everything in place. So it seems to have worked out so far for us.
And you were, your hospital was selected as a site, but that was, you did not anticipate that, I believe, earlier on.
Correct, yeah. So we anticipated getting vaccine for our own employees, but then once we received our first shipment of Pfizer, the state actually notified us saying, not only is this for your employees, but also 9 other area hospitals. And so we had to try and figure out how we were going to work with these other hospitals to get vaccines for their employees, make sure they were eligible employees. How are they coming to our hospital? How would we, track that kind of volume, because we are a smaller hospital in the capital region. And so it was a lot of meetings, lots of phone calls, and really just work from everybody from nursing to registration, IT, huge effort.
Right. So when did this message come from the state? And how did this impact your logistics? And you kind of mentioned some of that now, but elaborate, tell us some of the issues that came up.
Yeah, so it had to have been Tuesday or Wednesday of that week. So initially we had our 1 sleeve of Pfizer vials, 975 doses, and then we were on track. Okay, we can get this many of our own employees, and then they came back and said, day 2 or 3 of our immunizations, oh, you actually have to share these doses. And then they kind of allocated however many went to which facility. And so, it was just, you have to do what you have to do. And the more people we could vaccinate, obviously we were happy to try and accommodate getting more people in the region vaccinated. But yeah, just very challenging, and especially because at first we didn't have a scheduling tool, so we weren't quite even sure how to track or make sure these individuals who got a first dose with us but weren't employed by us would come back for their second doses. So, you know, just a lot of counseling them, trying to work with their directors and ensuring they would come back to us and that the state would send us more vaccines for the second doses for these individuals too. And so, very tricky.
Okay, thank you. Raul, how is it 3 months later from, you know, we started mid-December, now it's mid-March. How did your program differ today? How does it, you know, contrast to that early beginning? Where are you now compared to the beginning?
Well, I mean, we're doing better, but you know, if you look at the total number of people, we have about 40 million people in this country that have had both vaccines, and if you look at the Black and brown population combined, it's only 3 million. You know, and I just think that's the area that I don't see too much of a change. You know, we have centers that actually were put in inner city where they're highly populated with Black and brown populations, and very minimal African Americans and Latinos are going there because of the trust. So, you know, they're having almost 14,000, you know, scheduled slots, and only 7,000 are being filled. So I think an education piece is becoming a bigger thing now, and we've been pushing for primary care to really be more engaged in the whole process. I mean, you know, like I said, we had templates, we had bi-directional interfaces with NYSIS, you know, to be able to do that. So it's not very difficult to do, but it's real important, you know, to really try to use that kind of an approach to help the doctors learn about it. I think we really got to do, you know, it's almost like primary care physicians feel left out of this whole equation, and that's what our mission is. We're vaccinators, so it's still not there, but hopefully it gets better.
Thank you. Patti, your program, your vaccination program today versus 3 months ago.
I mean, obviously it has changed a little bit. You know, we're a little smoother. We're down to a bit of a steady state of, you know, knowing at least that we're going to get vaccine. We may not know how much. But, you know, it really has been an up and down, you know, of expanding and contracting with the allocations that we would get from a week-to-week basis. And, you know, again, the guidance and the regulations from New York State sometimes, you know, would say, you know, you're going to get these vaccines and you need to use them within a week. And yet we haven't, you know, send out appointments for patients. So no one would ever run a business that way, especially in healthcare, you know, when we're actually caring for patients' lives. And, you know, even in the beginning, and Megan mentioned it, like the eligibility criteria was pretty strict. And, you know, we didn't use any scheduling platforms either. We, you know, started with maybe an email, but then we were worried that people would share that email and forward it to somebody else, you know, with a link. So we quickly had to ramp up to a way that we knew that the vaccine was being offered to the people that were eligible, those, you know, kind of phase 1A, phase 1B, and then, you know, obviously being equitable within as well. So we put a lot of thought to it. You know, 3 months later, we are doing a lot of things that we can get into. I mean, in a little bit of being equitable and making sure that we do outreach to, you know, all of people of color, you know, our communities that are underserved, you know, even if we are in this big hospital system.
Thank you, Patti. I'm going to switch to you, Marty. You've heard some differences here. We're all in New York State, but obviously we all know from the news that things are done differently in different states. Eligibility criteria, you know, been different. There are, I guess, my recollection maybe a month ago, more than a month ago, Florida basically anyone above in senior age group. Phase 1A was basically open to everybody in that age group. May have been 65 or 60. Just each state is different. So talk to us about the differences you see here, and how about the maybe give us a bit of a flavor also about what's going on in Canada, and how things may have changed over time too.
Certainly, be happy to do that. Seb, if you wouldn't mind putting slide 3 up there again. We have a bit of a state-by-state usage percentage, which I think is quite interesting. So we'll spin that up. And I mean, there's some really interesting comments from Raul and from Patti as well. And I love that Patti used the word equity and not equal, because I think there's some really interesting public health connotations to that I wouldn't mind poking out a little bit, but I think that's really great. So from the dosage used percentage, so the right-hand column on both of these tables, so you get a sense of what's been distributed and what has actually been used, and the variability by state there. You know, some, and notably probably the smaller states, of course, have a smaller volume to use, so they tend to kind of make use of it, and things move along a little bit quicker. That may be, of course, much more challenging, I think, for the larger states, but the numbers are pretty respectable, I'd say. You know, for New York and for Florida and for Texas, they're all kind of good numbers. Some interesting numbers, I think, in the federal agencies area on the right-hand side. So they don't show population denominators here, so there's no percent coverage, but the usage numbers vary, of course, and probably some of the, maybe more remote communities and underserved communities might be a little more challenging. And I'm kind of looking at the Indian Health Service there. The prisons, I think, is an interesting one, and certainly, floating above 100% doses used, and probably indicates that that they were making sure they got every drop out of each vial. I think essentially, if it was a 5-dose vial, they probably were pulling that extra 6 dose out of there, something like that, and kind of moving it across their population fairly quickly. The equity and equality discussion, I think, is an interesting one, and I mean, I wish I had a graphic for it, because it kind of lines up something like this. So you have, basically, 3 people. Think of 3 people looking over the baseball outfield fence, trying to watch the game, and you've got a tall person, a medium-sized person, and a shorter person. And from an equality point of view, you'd give them all the same size bench to stand on, right? And so the tall person would, still be seeing what he saw. The medium person, might just be peeking over, and that shorter person is not seeing anything at all. But that equity view, I think, is much more important in public health, and that basically says that short person's getting a very tall bench to stand on, so they can see, and it kind of scales down, so everybody's looking over the fence now, right? So, when Raul's talking about his underserved populations, driving vaccine out more quickly and more efficiently to those populations, really should be a focus, as opposed to, making sure that we've got, oh, excellent, thank you for that, whoever put that up there said. That's what I was thinking exactly. And so making sure that, that we are driving out to those underserved populations is really important. And that can be challenging when, we don't have good mechanisms in place for making sure that kind of people trust the system that they're in. And we can talk about that a little bit more later on. Having faith and alignment with your community leaders, as well as state leadership, and making sure that you've got kind of values aligned there is really important. And where that's challenging, making sure you're allowing your general practitioner population to serve to the best of their abilities as well. So thank you, Amin.
Thank you, Marty. Follow-up question here to you. Best practices in different areas, and that if we think internationally, probably Israel will be sort of best practice. They got the vaccine in December. They started doing that. I know the United Arab Emirates, they actually got the one of the Chinese vaccines before that, before December, and started doing vaccinations before Israel. But at least in that region, they come in behind Israel. And so Israel's, I guess you can say, is best practice internationally. In North America and in the U.S., you know, which states are doing a better job, or within a state, they're, you know, I don't know, New York City versus the rest of New York State, but, you know, where do we find the most effective programs and best practices?
Well, there's, I mean, some interesting.
And I guess depends on perspective too, right?
Absolutely. And what is the goal? What are the drivers for those organizations and countries? And you know, certainly in the Israel situation, I mean, they are, I mean, no matter how you cut it, a unique situation in the world, and have some very different drivers, but also have some very different thought processes around compliance, and just because of the, you know, the overall safety concerns that they live with every day, you know, people comply with, you know, what is being put forward to them for the most part. I mean, there's obviously different populations, and they deal differently within the country, but for the most part, and having worked on the ground there for the last few years, so just some really interesting mindsets around complying with safety orders in general. And I think that spilled over into the vaccine uptake. They also, you know, not a big population, of course, it's not huge, 9 or 10 million, something like that. But very well covered in terms of their health information system structure. So, you know, they have good registries to start with, and they were able to very quickly highlight their vulnerable older populations, of course, where they started, and really good connections with their primary care, I think is true as well. So, you know, people are assigned to a physician, and much of the delivery, I think, was at least organized based on those principles. And they made some interesting decisions as well with, you know, how they were going to partner, loosely I'll use that term, partner with the manufacturers, and what information they were willing to provide as a country to help. You know, honestly, I think they helped decision making worldwide when it comes to the efficacy and safety of some of the vaccines that were used. And I see even now Canadian provinces and federal government making decisions based on some of the research that came out of Israel. So I think many people benefited by their early agreement to go hard on the vaccination side of things. The UAE, you know, is certainly an interesting contrast, and the motivators are probably quite different. So certainly Dubai itself being the international travel hub that it is, and the dependency that they have on travel and tourism and people kind of moving through the country. I think that was an early driver for them to make sure that they could get their economy back in place as quickly as possible. And so very early on, you know, even November, December timeframe, they had emergency approval for their first vaccines that they were administering to their healthcare workforce. And again, we got some really interesting safety and efficacy numbers coming out of those numbers that many places benefited from, which I think is great. So, and moving those kind of learnings into the North American situation, I think, as I say, you know, the Canadian healthcare landscape is quite different than the U.S. landscape, of course. And while we do have some provinces that are having primary care physicians administer, that is not the norm. Generally, it's publicly organized vaccine mass immunization sessions that are being promoted. Because of the cold chain requirements for the first couple mRNA vaccines, that necessitated being in some of the big hospitals, of course, in our larger communities, and we had shipments go directly from manufacturers to those holding points. We had some really interesting. I think Megan was talking about acquiring their deep freezer, for lack of a better term, and we had some interesting things pop up. I think there in some Canadian environments, we had on our East Coast, where there's still a significant fishery. We had some of our sushi producers actually donate their ultra deep freeze refrigerators to public health to allow quick storage of vaccine. I think that was really cool. And on the other end of the scale, we had some of our nuclear research facilities who also had big deep freeze capabilities, and they happened to be in slightly remote locations for maybe good reason. Actually helped in those areas to store vaccine for their region. So some really great cooperation, I think, happened across the board.
Wow, lessons learned. I would say this is a big one. Tip for all of us. Raul, you need a deep freeze. Who to go ask. All right, thank you, Marty. Switching gears to you, Patti. Tell us about challenges. I think we've kind of touched earlier already about some of that, but dig a bit deeper into challenges. We've covered supply, we've covered scheduling, but did you have the same? And how did these challenges evolve over time?
Our challenges have been many. Some of it is, again, following the very strict criteria that the state has provided, and abiding by it, and again, trying to do both things. Hurry up and vaccinate and get shots in arms, but you're going to get fined $1 million if or you need to and that's real. Or you need to send back the vaccine if you didn't use the entire amount, but you happen to have extra, you can't just, give it to anybody, right? So it's that challenge. It's still there. It's less, right, as the criteria is expanding, and we're, able to vaccinate more and more patients and staff and people in general. But our challenges were also vaccinating our own staff to begin with. And, if you see in the media that, people are lining up to get the vaccine, yes, that is true. But there's also people definitely not lining up to get the vaccine. And, Marty mentioned it before, where, we need to meet people where they are. We need to provide information and communicate and outreach, and that is part of the challenge as well. The criteria initially was to make sure that our healthcare frontline workers were vaccinated, right, because they were most at risk. But that didn't just mean the doctors and the nurses. That also meant, the people who, take care of the environment in the hospitals, for example, right? So there's equity there, but of course, you don't have to make, I don't have to be an epidemiologist like Marty, to know what the data shows of who looks like, and what people look like depending on their roles, right? So as much as we wanted to make it equitable, people really weren't still comfortable, and that trust piece is still there, whether they trust the healthcare system, a lot of good reasons why they don't, and how much can we do to really make things equitable. And, so we've done everything we can, as a health system, partnering with community-based organizations, going out to churches, going out to grocery stores, now, not in the beginning, right, obviously, because the criteria was very strict, but now that we can target and look for patients over 60, or underlying conditions, we can kind of widen our net. And I know this is HIMSS and it's healthcare information, but, high touch also, right? Not everyone has the ability to use a smartphone or schedule easily, or even when there's an application to schedule, even that, can be a barrier. So we do outreach, we call patients, we use, geomapping to see where there's, low broadband, for example, and we reach out to patients that way in those areas where we know that, for, again, not to get into different kinds of conversations, but we know why broadband is low in some areas of the city, call them and invite them in for an appointment. So challenges are still there. I think it's how we meet them.
In terms of the, you mentioned earlier the challenge of training on BLS, and for those who are not familiar with that, could you explain what that is? Because I realize we may not have all clinicians here. Absolutely.
Yeah, BLS is basic life support, so it's CPR and first aid, and I guess now with more millions and millions of people getting the vaccine, it's easy, I guess, to forget that, initially this is, and it still is, under an emergency use authorization. So, it is not a licensed product yet, and it's only with numbers do you know, and again, Marty's the epidemiologist, but only with numbers do you know what the risks are and who's going to have an allergic reaction and who's going to have any other type of reaction. So, at least in New York State, they thought ahead and thought, well, at least let the vaccinators in different roles at least have BLS training.
Thank you. Raul, what challenges other than lack of supply coming to your primary care setting have you encountered? Raul, if you may still be on mute.
Yeah, what was, I'm sorry, what was the question again?
So you mentioned early on that you had or you still have difficulty getting vaccine for your primary care practice. What other challenges have you encountered, and do you still encounter? And did those change over time?
Yeah, I think the vaccine is the biggest situation. I think just being able to educate the population. If they're your patients, there's trust, so that becomes a little bit easier. And I think that the logistics of just which vaccine you get. Moderna is a little bit easier for our offices. Pfizer will require a pharmacist to put things together. So, that's still a little bit of a tricky issue. And hopefully the J&J, when we get it, will make things a little bit easier. And the follow-up will be a lot easier if that's the case. But I think with me in primary care is just to plan for this, to have enough staff, because that was also very tricky from time to time, having the right amount of staff to be able to tackle a task. And I think the highest we've done is 500 in a day. And running it out of a primary care office, that's not that easy to do. But we were able to kind of accomplish it. But I think that's it, the logistics and making sure that doctors kind of know exactly what needs to be done, and to make sure we don't make mistakes with the submissions, because we don't want to get fined in any way too.
Thank you. Before I go to you, Megan, asking about challenges, and I know you have some unique ones with the when the state asks you to assist or cover several other hospitals. I just, Raul just touched on just having enough people to give the vaccine, and so and he touched on the vaccine supply itself. So we have basically human resource supply, we have a vaccine supply, and a bunch of other issues as was covered, scheduling and people's access to broadband and that sort of thing. So I probably should mention here that about a couple of months ago, we were at about 1 million doses a day. A month ago, we were mid-February, we were at about 1.5 million doses a day. And the that's 7-day rolling average. So that was about 2.5 million doses a day. So I think we're making progress in terms of the vaccine supply, in terms of human resource supply. I think the scheduling has gotten better. But tell us, Megan, about the challenges and how you solve those and how you address them.
Yeah, so we had a lot of, obviously, the similar challenges to everybody else as far as administering vaccines, getting the right people in when eligibility was very strict. So we, especially with our own employees, had kind of like a list of eligible employees at first when everything started, who were our front-facing, frontline physicians, nurses. We did have EVS workers in our initial one. So, we addressed that pretty well, I would say, but there was a lot of challenges as far as especially extra doses went because they come in multi-dose vials. So in the beginning, we have a list of eligible employees, but at the end of the day, we didn't have a scheduling tool, so we might have had 3-4 extra doses out of a vial, and then the state was very specific on, you can't use this, for this other employee because they're not eligible. So that was a big challenge, trying to, I guess, have a call down list, trying to find other eligible employees, especially in the beginning, who are willing to get the vaccine. Not having other coworkers or anecdotal people to talk to, to go off of it. So we had a lot of vaccine hesitancy in our very first eligible employees, and obviously the extra doses at the end of the night type issues that we ran into. And then we did have, people administering. We relied a lot on our nurses to provide vaccines and our PAs, a few doctors, but then we also had to find more people to do the volume that we had to do once we had to do the area hospitals. And so we actually incorporated our pharmacists who were able to vaccinate, but that presented a challenge because pharmacists in our system were not allowed to administer medications. So we had to turn on something specific in our EMR to allow pharmacists to document administering a medication for the vaccines. And then we have since then created kind of a committee of different physicians who have been good leaders in our hospital that address vaccine hesitancy, and they go around to different departments and kind of explain vaccines to the employees and what their fears might be and try to answer their questions. And then kind of as it's progressed, we've even had people who don't necessarily have vaccine hesitancy, but they've started having a preference on which vaccine they want to get, which can be challenging because, we only have so many doses of Moderna or Pfizer or maybe Johnson & Johnson eventually. And so that's a little interesting too, that it's gone from, I don't know if I even want this vaccine, to I'm going to be picky about which vaccine I actually get. So.
Thank you, Megan. That's interesting. Let me switch gears to you, Marty. You've heard and you gave us a good tip about the deep freeze and the collaboration there. How the issues that we just heard about, that's gonna lead to another question in a few minutes. But these issues, could we have anticipated them? To what extent? Lessons learned. We heard about vaccine supply, which is improving. We heard about human resource supply, which is improving. We heard about government rules. The state says you can use this doses or you can't, and you get fined if you go right. You get fined if you go left. So it's coming at you each and every way. How can we address this now as a lesson learned going forward?
Well, the fines is an interesting one, and that's surprising to me. Maybe it shouldn't be, but is it an effective tool? I'm not sure. the stick is often not, not the most effective way of going about things. And really the delivery mechanisms, I mean, they vary so much, and I'm sure they vary within your state, as we're hearing. I'm sure they vary drastically state to state and within other states as well. And thinking about some of the remote communities and what's effective in those communities as well, I think is interesting. And certainly some of our First Nations and Indigenous communities that are fly-in only, we've had some interesting situations happen in. We've actually prioritized those communities early on, and some of the coverage numbers are quite encouraging there. Of course, they're fairly small populations that we're talking about in our northern areas. But the initial concerns about not being able to use the ultra low temperature requirement requiring vaccines, was definitely a challenge at first. We actually found ways to kind of make work as some of the storage requirements were loosened up a bit. So I think we followed a bit in terms of some of the change in those requirements and how they were applied. As that progressed in the early situations, we're now kind of applying those in the more recent situations. Canada, in some ways, we've been following along what's happening in other countries. We've not actually had the supply in a significant way until really the last 4 or 5 weeks. So we've benefited by drawing in kind of the experience of other countries and are starting to apply that now. I think the information management side of things is an interesting one that I wouldn't mind diving into a bit. And we saw during the early days of the pandemic, as states were starting to ramp up their contact tracing, lots of different ideas about how best to manage that, that huge volume, right? And we're into volume issues again around the vaccine distribution, but the mass contact tracing situation, basically we saw many states going to tools that were pretty unique to the public health world that we had not seen used before. So the client relationship management type tools, CRMs that are very focused on, tracking and communicating with, clients in a business sense for opportunity management. And so there's some interesting tools that were put in place there and were very rapidly developed to scale up to kind of large scale communication in terms of being able to have automated dialing out to clients, getting text messages out to clients to help alert them to situations. That started to get more effective. But it's interesting what we're seeing now is that some of these organizations are really struggling with the data model that they essentially neglected as they put these tools in place, and they tried to repurpose the data model that just was not really appropriate for public health purposes. And as we start to get into some of the monitoring and evaluation, these organizations are struggling now to find their feet and to reestablish the data streams that they need. I think we're seeing something very similar on the vaccine rollout side of things as well, where again, CRM tools are being used to help with the mass communications at a large state level, I think, right now that we're talking, as opposed to kind of individual county level or local health department level. The same situation is really, really happening, where the data model behind the communication tools is not sufficient to support what we need in terms of being able to monitor adverse events, for example, and being able to track the adverse events following immunization by lot number of product that was provided, so that people can do the safety assessments and make sure that we are not seeing adverse events that indicate safety signals that folks should be aware of. And that does make the communication harder as well. So not being able to pull that data as quickly as possible to inform public health leadership in terms of the decision making that they need to do is a challenge. And so we're certainly seeing with our clients now the need to reset those data models, to start looking at how that's happening for COVID and the AFI, adverse events following immunization, side of things, so that we can actually really effectively track coverage, but also track the safety signals that we're seeing. And that's extending out from kind of our provincial level situations to the community and affecting how vaccines actually being taken up by those populations. So that, that I think is a lesson learned that we didn't quite get in place from the contact tracing side of things, and that we are still struggling with, I think, as we move through here. And we'll continue to try to reset as we move kind of through the remainder of the pandemic, and start to then think about how we use these systems for all the other diseases of public health significance, as we move kind of beyond the COVID realm.
Great, thank you. Patti, I'm going to stay with you, kind of that data and maybe data and analytics aspect of that Marty got us started on. So share with us, he mentioned some challenges and I don't know, maybe successes or moving to a success by pivoting around the data. So talk to us about data management in your part of the world.
Yeah, so we have a team of analysts, data analysts, data science. We're a big health system, so we're lucky in that way. That didn't mean that we didn't go to spreadsheets in the beginning, because that's what we had. But we quickly created a data mart to keep track of, from the eligibility, who actually took the vaccine, who was still left to outreach, kind of all of those processes, went from spreadsheet to a pretty Tableau, and a data mart. But we still struggle, right? Because, we had to answer questions from the Department of Health that kind of changed, felt like daily. The definitions, the questions, right? Once you started to have, again, a good cadence, and okay, these are the questions that they're asking. We're going to gather the data. They would ask different questions. So, and it would be, and as recently as just in the last couple of weeks, they've now gone to weekly, thank goodness. But, as recently as just a couple of weeks, they were asking questions in anticipation for, whether the federal government was changing the allocation to the state, and an expansion of criteria. We started looking at that as, kind of reading the tea leaves of what was coming. Just from that side, but we are very lucky in a way to have a pretty good team that are analysts and data scientists, and unlike either other states or Canada or other countries, we don't have readily available registries of patients. That's just not where a lot of us are. However, at Mount Sinai we do have a population health department where we do track patients based on different criteria, and we actually were able to utilize that to do some of the outreach as well. So, challenges, but I think we've risen to it. We now have automated certain things. We use Tableau, so we're away from spreadsheets, thank goodness, and we're using our scheduling tools to be able to, use that information and predict a little bit. And then obviously the last thing is, inventory management. So we at least had an EMR that was able to capture that. And, I think Megan would know a lot more about that on the pharmacy side.
So before I go to you, Megan, let me ask Raul, in terms of data, there are a lot of data that are requested for each vaccine dose, vaccinee, so talk to us about the data management in your part of the world.
Yeah, I think for us a lot, we've had systems where we've used SharePoint and a lot of GUI interfaces in the background. to really extract a lot of the EMR data, which made it a lot easier for us. A Tableau was really good too, because at least we could publicly face that, just to keep the community involved. So we did it a lot for, like, when the COVID testing was going on. Not only were we picking out the races, but the zip codes. We did the same thing for the vaccines. So as they're done, whether it's 1 shot, 2 shots, we ended up extrapolating, again, who's getting it, what zip codes are getting it, and to make sure that we're getting an equal distribution. Because, we were seeing some zip codes that had higher percentages, and the ones that really needed it were lower. So we try to focus our energy on that. I think the automation is really cool because it allows us early on to really extrapolate who needed the testing and who needs the vaccines. Putting the automatic callers, extracting a lot of the, sort of transportation and other things that was really important, because language is a big barrier, and I don't think we did a great job with that. We speak 18 languages, so we a lot of times we're doing English and Spanish, but forgetting about a lot of these other groups that are around. So, one advantage to us is we're a health home also. So we have, about 220 people that work for us. So we mobilize everybody to do a lot of different things. And I think that was important. Getting people transportation, because it's a major barrier that we often don't think about in order to get them in for the vaccines. It wasn't just that. We have a mobile unit, so we've done a lot of, mobile health type of models. It was nice because you can actually move the vaccines with you. Otherwise, if they went to one center, they had to stay in that one center. But with the mobile units, it was easier to kind of really go to these different sites and provide a different type of approach. All the data was being extracted. We have a Wi-Fi in the mobile unit. It goes out a mile. So there's a lot of health equities in terms of digital divide. And we were just getting people to really get out there and, and really bring the information that we needed in order to get these people processed through. It's tough to do 350 to 500 people a day. Some people don't read, some people don't write, and they show up. And so, there's just those types of things the technology made it a lot easier to kind of perform.
Great, thank you. Megan, data management, especially that you have several other households now that you took on, not just yours.
Yeah, so we're very fortunate as far as data management went that our EMR crossed over to NYS. So that was a big data storage crossing over thing that had to happen as far as reporting to the state the doses. So luckily our EMR was able to just kind of automatically pull that information over there. And then we do have a lot of various reports that we've been able to run and kind of look at data of the populations we're doing and our employees who've received vaccines and that sort of thing. So it's been very helpful having an electronic health record in that regard. And then we've also used it, we work in conjunction with the College of Pharmacy here in Albany. We're doing a study on some Moderna side effects that seem kind of unique to Moderna, so we're able to extrapolate the data from individuals who have received those doses and had side effects, and if they've reported them to the CDC's VSafe tracking record. And so it's kind of nice that we have that much data we can pull from, and that our EMR allows us to create reports that can track that type of thing too.
Oh, great, thank you. Let me stick with you for one more question, and then I'll pose the same question to you first, and then the others. And that's about the disparities. We saw earlier that picture. Then there's oftentimes see the confusion between equity and equality. So, but what are you doing in terms of addressing healthcare disparities related to the coronavirus vaccine?
Yeah, so we're specifically in our area, we have a large Guyanese population and a large Black population. So those are where we see a lot of the vaccine hesitancy and where we're really hoping to put more outreach into. We have a lot of discussions of using the Johnson & Johnson vaccines for these populations because it's a one and done shot, and maybe they're more likely to take that versus a 2-dose vaccine. And then we're also in talks of working with the health department here locally at the county level and bringing the vaccine to these individuals, because, you know, going to a hospital to get a vaccine, when there's also a lot of distrust in minority groups of healthcare, it's just kind of a daunting thing. Or, you know, you don't have access to schedule with our scheduling site now that we're using a scheduling tool. And so those are kind of the things that we're hoping to implement more of. We've already partnered with the county for one vaccine clinic, but really to hit more of our population, because there is a very large disparity in our area specifically for those populations.
Thank you. And we want to get to some more of the audience questions. So rapid fire here. Marty, I'll go to you next. Anything else in addition to what you shared with us about the indigenous population in Canada?
Well, I think generally, as we're talking about kind of misinformation, and maybe the infodemic was a term used early on in the pandemic, talking about misinformation out there. I think across the board, no matter what community it is, it's really important to establish trust in the leadership, and to make sure you've got a balance between political and public health leadership. And quite honestly, I think who gets out in front of the issue depends on kind of who's the better communicator of the group of people. And we see a real mix in many areas of the world, and I know there are quite a few mixes as well in the US. But having, oftentimes having the political leadership out in front is probably not the best way to go. It really just relies on who's the stronger communicator. And I think when it comes to compliance, and whether it's compliance with public health orders or vaccine uptake, I think when people's values are aligned with whoever the leadership is, that's when you get the best uptake. And the closer that is to the front line and to where people live, probably the more effective. I won't claim kind of coining that little bit. That kind of comes from Mark Carney, he's the former governor of the Bank of Canada and the governor of the Bank of England, and he's been touting this idea in terms of not only the pandemic, but also around climate change and how people actually action what's happening in that space as well. The messaging is vitally important, and it really relies on trust.
Thank you. Yeah, the trust is really important, and you hit on the political figure versus a public health figure, and some of the states have used the latter strictly. And I think from what we've read in the news, that they are in a better place. Patti, you get the last answer on the disparities question. Raul, for example, shared with us that he has a mobile unit to reach out to different underserved populations, and Megan shared that she's working with the Department of Health. What are you doing in New York City?
We're doing a lot of things. We also have a mobile unit out in Long Island. And as I mentioned, we use some of the technology and analytics tools to be able to outreach to the low broadband. We've had existing relationships with, as I mentioned before, with churches, and again, we have 7 hospitals, so they're in different areas, and each hospital is its own population, right? Staff and patients. So we look to make sure that we do, again, the outreach, even internally. We've been using our diversity councils to have town halls, and and there's kind of different types of town halls. There's town halls where you have incredibly smart, intelligent, MD, PhD, and everything else, behind it, explaining the science, and that's very important. But then there's other town halls who, where we've had panels of people that, are like a lot of us, right? Are just trying to digest the information that's out there, and how do we come to a decision? And so we're basically just trying to get the information out there and having people make informed decisions and not just listen to what's on the internet or, unfortunately, it's social media is out there. But the more that we can just allow for conversations and ask questions in a very collaborative manner, I think that's really what our focus is. And you said I could have the last word. I will tell you what I'm looking forward to when this vaccine is just like another vaccine and nobody asked for one or the other, just like the flu. And it's part of care of the patient.
Thank you. I'm going to switch gears here to Dr. Bania. Margaret, in other questions from the audience?
Okay, yeah.
And I'm going to step back, take a break.
I mean, yes, we've had some questions that come in during the conference, and parts of the questions have been responded to, but we'll go over them again, and if some of the panelists want to maybe talk a little bit further. Okay, so one of the questions here is they're saying that it seems like there are more and more vaccine appointments available, and what are your organizations doing to increase the interest in taking those vaccines, especially with the populations that have lower immunization rates? I see Patti shaking her head. You did kind of address this in different approaches. Yeah, if you would like to talk about
I did, but and we don't have the only word here, but you have to keep doing it, and you have to continue to have the conversations, and sometimes people just need time. Not everyone wants the iPhone 12 the first day. I mean, some people want to wait and see how things go, and so there's been a lot of conversation around hesitancy, confidence, whatever you want to call it. I mean, everybody comes at it from different reasons of why they're making a choice or not making a choice. So I think, it's just multi-channel and just continuing to have that conversation.
This is Dr. Vasquez, but I think the key thing is people want people that look like them involved. So it's going to be real important to get that involvement. In the Latino and the Black community, the church is on top, doctors are second, politicians are third. So just knowing that, it becomes real important who to have around the table and where the trust is. But I think it's real important to get people that look like the community so that they can easily, guide them, and at least there's a trust, because like you mentioned before, trust is still a big problem within all these communities because of a lot of atrocities that happened in the past.
If I may, Margaret, the Kaiser Foundation has been surveying individuals, and one of the interesting things I think this was published in January of this year. What sort of a message rings true with individuals by age, because as the vaccine gets younger age group, that's going to be another challenge, by ethnicity and even by party affiliation. But the three top messages were the vaccine has been shown to be highly effective in preventing illness, preventing COVID-19. The second one, the vaccine will help protect you from getting sick from COVID. And the third one is the vaccine is the quickest way to return to normal life for most people. All right, or especially if most people get vaccinated. So those top three messages seem to resonate with most people. And so on to the next question.
Okay. We have a question there saying that they've heard of the different stories of ineligible people receiving vaccines, and how are their nurses and staff trained to check this eligibility for those appointments? And do you think it's fair to put that verification burden on the clinical staff?
So if I can take that, so we don't put it on the clinical staff at all. Number one, we do it by appointment only, but New York State has a website where before you actually, as a patient, go to any place to get a vaccine, you have to say on that website that you're eligible, and you know, it puts the onus back on the patient, because you know, and Margaret, whoever asked that, you know, that's right. There's no way that, you know, the clinicians are going to verify and say, yes, you fit, no, you don't fit. You know, we limited by the amount of appointments that we put out there. So if a patient comes in with a scheduled appointment, but also the patient has to say, yes, I'm eligible by all the criteria that New York State has.
Okay, we have a question of how is your facility dealing with the leftover vaccines at the end of the day? Megan, do you want to maybe? I think you did talk to some of that before.
Yeah, so now it's a lot easier again because criteria is a lot more broad out there. So we do have kind of like lists of people who are eligible who meet at least, you know, one group of the criteria. And so in addition to having appointments, which really helps because you have a ballpark of how many doses you'll do in a day, we also have kind of like a call down list where if we have a no-show or we had to open an extra vial and we have a few extra doses, we tell these people, okay, you're on alert, you know, if you get a call around this time, please answer, and you're expected to be here in this time frame. And so it's much easier now to manage extra doses, and we definitely have a long enough list to use the doses every evening. So it hasn't been too bad of a process now that criteria is wider.
Okay, thank you. Do we have time for one more question, or? Moving on.
Yeah,
I think so.
Okay.
Well, we have 1 minute, yeah.
All right. We haven't, and this might be their last question here. How do you, it's about the online booking, and how do you make the appointment available online, and the link with the city-state booking systems. About which one of our panelists would want to talk about the online bookings?
I didn't really hear the question, Margaret, but I'm going to assume there's online bookings for the city, the state, and the federal sites. And, you know, I think all of the hospitals and systems that we're associated with now. You know, you may not get it for tomorrow, an appointment, but, you know, at least it's available. So there's definitely a lot more opportunities because there's more vaccine now.
If I may mention just something, because it's come up increasingly in recent weeks, and that's homebound individuals. You know, even if you have transportation available for them, they cannot still go there, all right? So there are a number of organizations that are collaborating to send the vaccination to them. New York State has a website, which I think seems, my first glance, kind of looking at it, seems to be separate from the usual vaccination scheduling. So just, you may have to kind of look specifically for someone who's homebound. You may have to look maybe for a separate scheduling site than the one available for the public, for others who can go to a site.
Yeah, but this is Dr. Vasquez, but the website was really horrible. I mean, it crashed. A lot of people have a lot of difficulty working through it. Especially if you didn't have internet, you know, you're pretty much out of luck. So it didn't work as well at all. And I'm hoping that for the future, we come up with a better system. Because we had people that were making appointments and coming in thinking that, you know, we had a pop-up that they had already registered and they were eligible, and they were getting really confused and angry about it. But I don't think that system worked at all. I think we need to kind of invest a little dollars to improve that.
All right, back to you, Tony.
Thank you, Amin. And I'd like to take a moment to say thank you very much for doing a great job moderating this terrific panel. And thank you, Margaret, for helping to put this all together. Of course, our producer, I think, did a super job. Sebastian, thank you. And all of our panelists here, Megan, Patti, Marty, and Raul. Thank you for taking the time to share your thoughts and to be able to expand on what's going on out there with the COVID-19 vaccinations. And for those that are interested, as you can see, our next event is next week, and it'll deal with the innovation ways that technology from in this case, we're going to move off of the IT environment and go more towards the financial management side. There'll be some pretty interesting comments that'll be coming, and the panel is really a solid panel. So look to mark your calendars, come and join us for that one. And then go in April, take a look at our site. We're hooking up with the folks from Haney's for our next event. And for those that are not members, come and join. We've got some great things going on. And I'd like to say thanks to our president, Nick Cristiano, who has been helping lead the charge here for our chapter. Thanks again to everybody. Have a pleasant evening. And let me not be remiss in saying Happy St. Patty's Day to all.
And to you too.
Thank you.
Thank you, everyone. Thank you, Patti, Megan, Marty, and Raul.